I'd like to begin by thanking everybody for coming this evening. Preparing for this event has been a great experience for me. It's afforded me the opportunity to work with many colleagues across Dartmouth. Taking a look back at this event a couple of years ago, it started with a small cohort of alumni, TDI alumni, over in the Rubin Atrium at DHMC, where Dr. Weinstein addressed that group. Last year, I was afforded the wonderful opportunity to work with Chris Trimble to have our innovations talk for a broader audience. And this year, we have an even broader audience across MHCDS, DMS, the Geisel School, as well as TDI. So I'd like to recognize that. I'd also like to say that I've worked with my colleague, Dr. Ethan Burke, who's afforded us the wonderful opportunity to work with you this year, Dr. Brenner. So without further ado, I'd like to welcome our moderator and introducer this evening, our Associate Director, Richard Johnson.
Hi, I'm Rick Johnson. I'm the Associate Director for the Dartmouth Institute. I started in January, so I'm very new to this job. I have no healthcare background, so I'm learning very quickly, and I'm very excited to be here tonight to introduce Dr. Brenner. Before I introduce him, I wanted to kind of talk about what's going on here at Dartmouth, at the Institute, and at Geisel. I'm sure most people are from the area. You're well aware that we had a transformational naming gift for the medical school about 3 weeks ago. The Audrey and Theodore Geisel School of Medicine at Dartmouth. Theodore Geisel was Dr. Seuss. They've been longtime supporters of Dartmouth. And so the family provided a transformational gift to the medical school. So we no longer call it the Dartmouth Medical School. You can call it Geisel like you call it Tuck or you call it Thayer, but the Geisel School is the new name for our medical school. Over the last few months, I'm sure everyone's aware that we've had a major change in leadership here at Dartmouth. Jim Weinstein, who used to be the director at the Dartmouth Institute, took over as the CEO at Dartmouth Hitchcock. Vin Fusca, who was his chief operating officer, left, and basically I'm filling Vin's position. Chip Shoba, who's the dean of the Geisel School of Medicine at Dartmouth, who's been here for about a year. He is now the acting director at the Dartmouth Institute as we begin the search for a new director. And then everyone's aware President Jim Kim was just named the president of the World Bank, and Carol Folt, who is the provost, has been named the interim president starting in July. So there's been a lot of changes here in the last couple months. The Dartmouth Institute's rolled up in all those changes. In June, the Dartmouth Institute is going before the Board of Trustees to lay out our 10-year plan for where we want to go over the next 10 years. We're working that right now. It's a lot of work, a lot of moving pieces. We're having a lot of input from the faculty and the staff. And hopefully by the end of May, we'll have that locked down, go before the board, get their approval, and then we'll be making some, I think, very important transformational changes at the Dartmouth Institute, focusing on our core expertise that we've been doing for the last 20, 30 years here, but also trying to expand our portfolio a little and market and brand the Dartmouth Institute to the world to let them know what great things we're doing here in Hanover. Those are the most up-to-date notes I have for what's going on here in Hanover, and so without further ado, I'd like to introduce Dr. Jeffrey Brenner. His life's goal was to ensure all families who live in urban, underserved communities receive high-quality, culturally competent, personalized family health care. He attended the Robert Wood Johnson School of Medical School and then completed his family medicine residency at the Swedish Health Center in Seattle, Washington. He's also an adjunct professor at the Dartmouth Institute. He's been a family physician in Camden, New Jersey for over 12 years and currently is the director of the Institute for Urban Health at the Cooper Hospital, where he spearheaded innovative solutions for improving the health of urban, underserved communities. He also founded and serves as the executive director of the Camden Coalition of Healthcare Providers. This coalition is committed to improving the quality, capacity, and accessibility of the healthcare delivery system in Camden. Dr. Brenner's work has been profiled in The New Yorker and on PBS's Frontline. And tonight, he's going to present a program on bending the cost curve and improving quality in one of America's poorest cities, Camden, New Jersey. Please join me in welcoming Dr. Brenner to Dartmouth.
Thanks.
Thank you.
Thank you so much. It's an honor to be here tonight. I really have valued my chance to come up to Dartmouth. It's sort of a sabbatical, getting a break from Camden and getting a chance to step away from the work I'm doing. The Dartmouth Institute reached out to me 6 or 7 years ago when I started to learn more about the Dartmouth Atlas, and Jack, it had a huge influence on me. And how it influenced me, I think, most was that in many ways it's a natural science approach in observing the world and looking at variation. And I've really kind of taken that lesson to heart as I've puzzled through and noodled through what to do with the data we have in Camden. That natural science approach to variation is a very powerful approach. And I'll talk about the lessons I've learned from the Atlas and how I've applied that to our work. So it's such a pleasure to be here, and every time I come up here I take good ideas back with me. Last time I was here I met Chris Trimble, and he gave me one of his books, and it had just a very big impact. It gave me words for the stuff I was trying to do. Over and over I've found that the medical community doesn't have words for the things I'm trying to do, but the business community does have words for what I think we're struggling with all over the country, and certainly in Camden as well. I want to start out with 3 slides. I know that it's an audience that knows a lot about health policy, but I want to do 3 slides about health policy just to frame this in a way that helps you understand how I'm thinking about the problem from a Camden perspective. I'm deeply worried about this slide. Many of you have probably heard about this data, but essentially, as you look forward from 2010 to 2080 into the future, the bulk of the federal debt is healthcare. It's the healthcare industry. And we have really no agreement on what the causes are. You could ask different economists and they would argue, is it price versus utilization? You could ask different politicians what the cost drivers are, and they'd give you lots of different answers. So we don't have any kind of political consensus in our country about what the causes of this problem are, and we certainly don't have any consensus about what the solutions are going to be. As you look forward, it grows and grows. Social Security is a very small part of the debt going forward. It's really just a math problem, which is the pay in, the pay out, the age of eligibility, longevity. We could fix Social Security with some very small tweaks, and you hear very little about that in the news. They're kind of equated as equal problems. Social Security is a minor problem. Healthcare costs are the major problem facing us in our long-term solvency as a country. The reason I worry about this in Camden is that when cuts come, they always fall the hardest on the poor. And it's the group that's politically the least powerful and least able to defend themselves. So the folks that I care about the most in Camden and in similar communities are going to have the greatest impact, because we're sort of at a fork in the road nationally, which is either we're going to rationalize the delivery system or we're going to start rationing. And we already do de facto in many ways. And what that means is that there's sudden cuts in eligibility, or there's sudden cuts in services, or some new barrier to care. And we've watched that happen over and over and over in places like Camden. There are 2 articles that have had a big impact on me, and as I look at Camden and I think about where the costs are in Camden, just in a very basic way, I see cost in 2 places. One is in fragmentation and uncoordinated care, and the other major cost bucket is in unnecessary specialty care. So there's a very famous article that many of you I'm sure have talked about, but has had a big influence on me in Camden as I think about struggling with these issues. It's a very famous article looking at arthroscopy, which is a bread and butter procedure. If you're a family doc, all day long you see people in their 50s and 60s or slightly overweight with swelling in their knee and knee pain they've had for a few months. You may give them Motrin, put an ACE wrap on, you send them eventually perhaps to get an X-ray, an MRI, you might send them to an orthopedist, and the MRI shows wear and tear in the knee. And they finally did a study to find out whether or not the routine procedure we're doing on these people works. Essentially what they do is they put a scope into the knee, they inflate it with carbon dioxide, and they do a trim job on the meniscus. So it turns out that if you're an athlete, this works. If you have an acute tear and you tack that down, But if you're an older patient with wear and tear, it doesn't really make any difference. And they finally did a randomized controlled trial, and they got people to agree to be in either one group or another, the intervention group or the sham arthroscopy group. A sham arthroscopy is where you put the scope in and then just pull it back out while you're under anesthesia, and you wake up with a Band-Aid on your knee and you don't know which group that you're in. So it turned out that both groups got better at the exact same rate. And we do 650,000 arthroscopies a year. So probably the reason that they got better is that if I took any of you out of work for 8 to 12 weeks, if I put you in physical therapy 2 to 3 times a week, if I told everyone in your household that you didn't need to cook and clean and that you can play a sick role for 12 weeks and took you out of work, you'd probably all be healthier at the end of 12 weeks. So that's probably why people who get arthroscopy feel better after it. Over and over and over, as many of you all at the Dartmouth Institute have worked on this kind of data, there are many examples. For the lay people in the audience, be aware there are a lot of things that we do in healthcare that simply have no evidence base and actually have evidence base that we do harm. So there's disruptive change coming in all this, and this is not unlike the disruptive change that Kodak experienced when the film went to digital, or the experience that Blockbuster Video had when Netflix came along. And I think, ironically, the disruptive change I think that's going to come in healthcare is going to come in the form of more robust primary care. But it's going to be primary care that none of you have ever seen before and may never experience because it's really hard to do. So this is a paper, the lead author is Rick Gaffilin, who currently runs the Center for Innovation at CMS. And this was a project done at the Geisinger Health System. And Geisinger is very unusual. And Geisinger is an insurance company that owns a hospital and employs doctors. So it's a closed system, and if they do the right thing, it falls right to their bottom line. That's very, very unusual in healthcare. The average primary care doctor has too many patients. So they cut the panel size of the primary care docs from 2,500 down to 1,800 patients, and they gave them longer appointments. So they got half-an-hour appointments, and they put nurses back in their office. Lots of primary care doctors no longer have nurses in their office. They have medical assistants in their office. They also gave them big chunks of time during the daytime to answer phone calls, to email with their patients. And lo and behold, patient satisfaction improved, doctor satisfaction improved, but most interestingly, they reduced emergency hospital utilization by 18% and 36% reduction in 30-day readmissions. They saw similar kinds of results at the group health cooperative as well. These are very unusual places in that these are fully integrated models. Most hospitals in the country, probably including the one here, Dartmouth Hitchcock, couldn't afford a 5 to 10% reduction in bed days. It would cause a dramatic disruption within the institution. So this is profound disruptive change in healthcare. And this is really going after care coordination for the most part. This isn't even touching the other part of the fat in healthcare, which would be the unnecessary specialty care for the most part. So I want to pivot into Camden, and we're going to come back to the slides that I showed you. This is a picture of the city of Camden. Camden is currently 79,000 people. It's 9 square miles. It's directly across the water from Philadelphia. It's like the St. Louis and East St. Louis or Flint, Michigan. It's one of the first, second, or third poorest cities in the country, first, second, or third most dangerous city in the country. At its peak, it had 140,000 people, and we've lost so much population that the housing is really obsolete. We have the same problem that Detroit has and Baltimore has and parts of Philadelphia has, which is no one wants to live in housing like this. This is in a part of Camden called South Camden. This is right around the corner from it, and this is one of the most contaminated census tracts in the country. This is an EPA Superfund site that has radioactive contamination that leached into the basement of these homes, which really rendered the homes in the neighborhood worthless. A few blocks from this, if you flush a toilet anywhere in the county, it runs downhill to a sewage treatment plant that's an open sewage treatment plant. So it smells terrible in this part of the town. And also there's an incinerator where if you throw trash away anywhere in the county, it also ends up in the census tract. So this is what happens when you don't have political power and political clout. You get the stuff that no one else wants. We also end up with a lot of the homeless people from the region and also the mentally ill, the addicted. These are in economic terms, the externalities of the region get dumped into a place like Camden. So we have very challenging political environment as well. 3 of our last 6 mayors had been indicted and convicted of corruption, and the city has been in takeover, the school district's been in takeover, and the police department as well. Due to recent cutbacks, we laid off half our police department, sort of a natural experiment to see what happens. So we were already the second most dangerous city in the country, and it's likely will receive the distinction again of being the most dangerous city in the country. So it's a tough place to do the work that I do, but actually, ironically, it's probably one of the easiest places in the country to do what I'm doing, because no one is fighting me over market share. That the market share dynamics in the healthcare system in Camden are such that, you know, the hospitals say, sure, you want more high utilizers, you want more Medicaid patients, you know, you can have them. The healthcare environment in Camden is fairly small, so I can, you know, I've known everyone there for 12 years, I can sort of put my arm around the place. So we've got 2 inpatient hospitals. One is an academic health center that's very large with residents and fellows. The other is a Catholic hospital. The third hospital closed down, and they just have an empty building there that now has a charter school and other sorts of things. There are 3 emergency rooms in the city, 2 federally qualified health centers, one that focuses on sort of the mainstream patients, and the other one is focusing on homeless patients. We have about 6 solo practice primary care offices in the city as well. So that's it. You know, I mean, you can take all the stakeholders and put them around a conference table. We have a lot of ruins in Camden. This is an old Carnegie library with a tree growing up through it. And this was my office. This, on the right side is a sneaker store, and on the left side was a check cashing place, and a whole line of homeless people over on the side of the office. And this was my dream. This was a great, great place to work. I had a wonderful time here because the feedback loops were very small. You know, when I had an office meeting, I walked up front, talked to my staff, we made a decision, and we instituted it immediately. So it was really sort of my laboratory for tinkering with redesigning primary care. We were all electronic and paperless. We also did group visits up on the 2nd floor, so I'd pull 15 diabetics together, and instead of running from room to room to room in ineffective increments of 10-minute visits, I would pull them all together upstairs, and I could bill for 15 minutes or 15 visits for all of those patients, but got to spend an hour and a half with them. We also did something called open access scheduling, which means I woke up in the morning and had an empty schedule. And this borrows ideas from just-in-time manufacturing of not queuing, doing today's work today. So when I woke up, I had an empty schedule except for the first hour, and as patients called the office, we booked them 9 o'clock, 9:15, 9:30, regardless of what they were coming in for. And my no-show rate plummeted to like 1 or 2%. So it's been done in many places around the country. The problem in this office that I had was that I was too far ahead of the business model. So in business, you neither want to be ahead of the business model nor behind this business model. You know, my wife joked that the only reason I had a small office like this was to buy more computers and electronic stuff. And you know, so I spent a lot of money, and now there are reimbursements and incentive payments for these things. But when I did it, there weren't. What really tanked my office were 2 things. One of them was that the managed care organizations in New Jersey switched from fee-for-service, from capitated payments to fee-for-service payments. So I went from getting a large cap check every month to getting payments of $19 to $35 a visit. And you have to run pretty fast from room to room to room in volume to make up that. And then they deny a $19 claim, and you end up on the phone arguing over $19. So the other thing that spiraled me down was that I became known for the high utilizer project that I was doing as part of the coalition. And the managed care organizations started sending me all their most complicated patients. The nurse care coordinators would say, why don't you go to Dr. Brenner's office? He really likes, you know, complex patients. So when I knew it was really spiraling down was when I walked into the office one morning and there were 6 schizophrenics sitting in the waiting room with back-to-back appointments. And a psychiatric day program had discovered the office and liked the fact that I could print out at the end of the visit all their meds and their visits. So, you know, that's called case mix. So I had an adverse case mix, and that really spiraled the office downhill. So the office is currently boarded up, and in this office I was seeing kids, adults, and delivering babies. So this is full spectrum family care. We were doing prenatal care there as well, about half commercially insured and about half Medicaid patients, and it was a Latino neighborhood. So just a really fun and interesting place to work. All over Camden, primary care offices like this are getting boarded up. So, you know, in some ways I think this is a foreshadowing of what's to come in our country. which is if you don't take care of primary care, in the marketplace of healthcare services, primary care will begin to fall apart. At the same time, what we've done in Camden is we built larger emergency rooms. So our emergency room capacity has tripled in size, and we built new wings on the major hospitals. So our specialty care and hospital capacity is expanding. My work in Camden really began very innocently, and this was the flyer that we distributed in January of 2002. And this was about 10 years ago, and it was pulling together small solo practice practitioners. These are docs that no longer do rounds in the hospital, so we don't get to see each other. And there turned out to be a really big appetite. The small solo practice providers came out and we started having breakfast together and did that for about 3 years and eventually incorporated into a nonprofit and invited the hospitals onto our nonprofit. We invited the federally qualified health centers, we invited behavioral health providers, the homeless shelter, and recently we've invited patients onto the board as well. At the same time, we began to build a data set, and this data set was initially focused on accidents and injuries. Because the city had such a high rate of trauma, I was very interested in seeing whether there was a gap in the rate of real injuries from the rate of reported crime. What I was seeing in my office is that kids would come in having been hurt, beaten up on the street, been assaulted, and they wouldn't report the crime to the police because they would say, what's the difference? No one will do anything about it anyway. And we were already the most dangerous city in the country, but I thought that the actual crime rate was probably much, much higher, and felt like the hospital assault rate, that the hospital billing and claims data might be a better description of this. So I had a medical student doing an MD-MPH project, and we put in an application to the IRB of the largest hospital to get all their claims data. We had absolutely no idea what we were doing. We got all this data, and we put it in Excel, and obviously that didn't work. We put it in Microsoft Access. We crunched it, and we eventually mapped it, graphed it, charted it, and we were just blown away by the power of this kind of claims data. People like me never get a hold of data like that. And my patients were in the data as well. It was incredibly compelling data. And as I'm struggling to make payroll every week, I can begin to see where all the money in healthcare is actually going in a very tangible, very community-based way. We now have, we over time went to the other 2 hospitals and applied to their IRBs. Over the course of about 3 years, managed to get all of the claims data from the entire city. And we just kept amending the same agreement. And at first we just had the accident and injury codes and then got all the diagnosis codes for the entire city for every Camden resident. So we have name, address, date of birth, date of admission, charges, receipts, insurance status, and all the diagnosis codes for every Camden City resident, stretching to 2002 to 2011. Even if they're uninsured, they're in the data set as well. This is business intelligence. Hospitals don't willingly share their business intelligence with people. It's very hard to build an all-payer data set. There are all-payer data sets around the country, but often they are state-level all-payer data sets that are very hard to get access to. So once again, it's very unusual for someone at a community level to be able to build a data set like this and access this. We had no money to build the data set, so believe it or not, still, this data set lives on 2 $50 hard drives that has open source encryption, password protection. I've got a 24-year-old master's student who's at Penn who, you're going to see a lot of the data that he crunches. And we use Microsoft Access and write SQL queries, a $1,000 piece of software that does probabilistic linkage to match people across institutions based on identifiers, and then ArcVGIS. So this is not a fancy operation. We have about 500,000 records with 98,000 patients. We learned pretty quickly that half the population uses an ER hospital in 1 year, that someone went 324 times in 5 years, someone went 113 times in 1 year. So far, the leading utilizer in the whole country is a Trenton patient who went 450 times in 1 year. The total revenue for Camden hospitals was $100 million per year for ER and hospital care. So that's Cooper, Lourdes, and Virtua for all Camden City residents. And this is mostly Medicare and Medicaid because it's such a poor community. People don't tend to leave the city for healthcare services. So this is a pretty complete snapshot of where people are going and what they're utilizing. I look at that number and I can't get my head around $2.8 trillion, which is what we spend as a nation, but I sure as hell can get my head around $100 million. And we're wasting a lot of money. I could buy a lot of diabetic education, a lot of home visits, a lot of primary care with that kind of money, a lot of health coaches with that money. In fact, community-based services are a cheap date compared to the expensive delivery system that we built. The most expensive patient was a Medicare patient, $3.5 million in receipts for one patient. 30% of the costs go to 1% of the patients, 80% to 13% of the patients, and 90% to 20% of the patients. That basic sort of 80-20, 90-20 rule is true everywhere you look in healthcare. I've looked at employed populations, it's true. If you look at Medicare, it's true. If you look at national healthcare spending, it's true as well. It's actually true of complex adaptive systems, that almost any human system that you look at, you'll see a small sliver of the kids in every school are driving much of the discipline problem, or in a single class driving much of the challenge. Even in criminal justice, a small number of people are driving much of the crime rates in a community. So this turns out to be just a basic property of complex adaptive systems. The most frequent reason to go to the emergency room over a 5.5-year period was head colds. There were 12,000 visits for head colds, 7,000 visits for ear infection, 7,000 visits for viral infection, 6 for sore throat, 5 for asthma, 5 for stomach virus. These are mostly insured patients. These are moms and kids with Medicaid cards in Camden who sit in emergency rooms for 6 to 8 hours. They call federally qualified health centers and they can't get in for weeks to months, and that's why they go to the emergency room. We're about to hand out 10 to 15,000 more Medicaid cards in Camden. If the Affordable Care Act goes through, the uninsured in Camden will begin to get cards, and we're already overrun as a system. We're not building new primary care capacity, we're losing primary care capacity. It turns out that the hospitals get $150, $300, $500, $700 for these visits. And I was getting $19 to $25 to $35 for these visits. They make a lot of money on this. So essentially what's happening is the residents that see the patients in the emergency room, the federal government pays the hospital $100,000 a year to hire those residents and train those residents, as well as indirect payments, and at the same time can bill the insurers for the care that the residents are delivering, as long as an attending pops their head in and signs off on the note. This is very lucrative stuff. We've struggled to understand this data, and there are 3 segmentations that have meant a lot to us. The worst segmentation of this data is by disease. I think if you segment this data by disease, it leads you down to very narrow strategies. There are 3 segmentations that we'd like to use. One is a geographic segmentation. The second is a primary care segmentation, so segmenting by the high-cost patients that belong to each primary care provider. And this third segmentation are the most expensive people in the whole city, so the complexity segmentation. This is a geographic segmentation, so this is a map of the city of Camden, and this is all the receipts, all the claims data over a 5.5-year period for Cooper, Lourdes, and Virtua, mapped out to the patient's home address, combined into one map. And this is mapped out, as I said, to the patient's home address. These are census blocks, which are very small geographies. The red areas on the map are 6% of the city blocks, census blocks, 10% of the landmass, 18% of the patients, 27% of the visits, and 37% of the receipts. So it turns out that over time, high-cost complex patients get aggregated up into similar housing. There's a word for this that's being used in housing circles. It's called a NORC, which is a naturally occurring retirement community. And that basically in the natural American housing patterns, it seems to be the case that people begin to congregate up into buildings. These 2 buildings are beautiful buildings with great management. The building at the top is full of dual eligibles. They are people in their 50s, and in Camden, if you're in your 50s and because of poverty, you fall apart 15 years earlier than you would in a normal population. So in the building at the top, 600 patients had $12 million in hospital receipts over 5.5 years. The building at the bottom is a subacute rehab and nursing home, had 300 patients with $15 million in receipts over 5 years. We spent about a year in the building at the top collecting stories, interviewing patients, videotaping patients, and actually doing community organizing in the building, and building a leadership cadre in the building of patients that can advocate for themselves. We've taken those patients to meet CMS officials, to go to Trenton. We've hosted federal officials and state officials in the building. And the reason I've done this is that healthcare stakeholders aren't going to wake up tomorrow and say, you're right, the system's broken. We're all just going to reform ourselves. A lot of us would put ourselves out of business doing that. And that unless there's external pressure on the healthcare system, we're very unlikely to change. So I need residents in the game. I can't possibly fix this without their help. And that's why we brought them onto the board as well. As we've begun to look around the country, I've gotten claims data from the City of Trenton. We've gotten address level, patient level claims data from the City of Newark and from the state of Maine, from 3 counties, and also from labor union in Atlantic City. And everywhere we've looked, even in an employed population, high-cost people are highly concentrated into buildings and turn out to be concentrated geographically. So this is Trenton, similarly finding buildings that patients are concentrated in from 2 hospitals' data. We found a similar pattern up in Newark from 1 hospital's data, and we're currently collecting the other hospitals. And these are maps from Maine, looking at Medicaid up in Maine, mapping it out, and it turns out that high-cost complex patients up in Maine in their Medicaid program are highly concentrated within town centers. And it kind of makes sense if you think about it. As you get more and more disabled, it's very hard to live in the middle of nowhere, that you begin to get concentrated over time into buildings. And what happens is we take these patients and we move them around in the delivery system. And every time you move a really complex patient around, quality keeps dropping across every boundary that you move them to. Our response to all of this has been to build a nonprofit coalition. And I had no idea that this was going to be the outcome of all of the work. I mean, this has been literally step by step process of saying, today, what are we going to do to make the city of Camden slightly better, slightly healthier? What can I do to make my friends who work in other primary care offices lives easier? We've incorporated into a nonprofit. It's called the Camden Coalition of Healthcare Providers. My board meetings are like Noah's Ark. It's literally a zoo. It is, representatives from each of the 3 hospitals, and these are, $1 billion entities sitting right next to solo practice primary care providers who might gross $300,000 a year and whose offices are being broken into and, can barely pay their bills, next to a homeless shelter, next to federally qualified health centers, and now patients around the table as well. And they actually are all from Northgate too. So the patients that we have are part of a group called Camden Churches Organized for People. It's a faith-based community organizing group. And let me tell you, the patients have wide eyes as they're looking around the table at the crazy discussions that start going on around the table. And they ask the most wonderfully naive, powerful questions around the table as well. It turns out that for most of this time, I've had an agreement with Cooper Hospital, which is the largest hospital, and we lease all our staff from Cooper Hospital. So I have a management services agreement with them, and we have currently about 34 staff. Our budget is about $3.4 million a year, and all of our staff are Cooper Hospital staff members. So that means that I can buy a 0.1 doc or a 0.2 nurse or a 0.3 social worker by not having to deal with HR. Also, all of our grant money sits at the Cooper Foundation, and I actually have the other hospitals contributing money. So I've got each hospital putting in $50,000 a year. Cooper puts in $250 a year. And we've got a Medicaid HMO putting in money as well. And the rest is foundation funding. We've now applied for our own 501c3, and we've got our own bank account, and we're moving the money over to us, but I'm going to keep using Cooper as our HR. It's really challenging. It's sort of like a Switzerland role, which is I need to be a fair and neutral intermediary between all these institutions, and it's very, very hard. They fight with one another, and they all trash talk one another behind closed doors, and they actually sue one another. While we were negotiating contracts for health information exchange, 2 of our hospitals were suing each other over who has the most top docs in the region. So there's these silly magazines that do surveys of who's got the most top docs, and all the hospitals send out emails saying, stuff the ballot box and vote for your own staff docs. And one of the hospitals put up a billboard saying, we have the most top docs in the region. And they had actually counted some of the staff of the other hospital, but the staff had voluntary privileges at that hospital, so they did a cease and desist lawsuit telling them to take the billboard down. At the same time, we've got all the lawyers there trying to negotiate a health information exchange. So this is a sort of a crazy environment. We've divided the organization into 2 halves, and one of the hardest times I've had is figuring out what's the org chart, what are the job titles, what are the data feedback loops? Like, how in the world do you deploy people out every day to run all over Camden and do good things for people and know that I've got inspired people doing the right thing every day when I can't watch them? It's a highly dispersed business model. And the closest as I read business case studies, I can't really find anything in the health literature that helps me understand what I need to do. It's actually much more like the Southwest airline business model, which is, every day those staff on a plane need to play nice, collaborate, they need to work as a team, and that plane needs to take off on time, land on time. You've got to have happy customers no matter what's going on, and managers can't hang over their shoulder. You just have to know that everyone's doing the right thing. So I've really cast about for models in other fields that help me think about how to divide the work we're doing up. So we've got half the organization is more simple. We call it operations, which is a health information exchange, which is real-time labs, radiology results, and hospital discharge summaries feeding in from Cooper, Lords, Virtua, soon to be Underwood and Kennedy as well. And this feeds into a data warehouse, and I have export access to the data warehouse. So I can dump that data out for building registries at the community level, practice level, but also I can dump out what are called ADT feeds. The most valuable data element in all of healthcare in the next 5 years are going to be the admission, discharge, and transfer feeds coming out in real time from the hub computer of every hospital, because that's the demographic information for everyone who's being admitted, discharged, or moving around or receiving services inside the hospital. The way that we use that data is I download every day from the Health Information Exchange, and we crunch it in Microsoft Access and spit out a report that has the name of every patient who's been admitted to the 3 hospitals in the last 24 hours, what their insurance is, who their primary care provider is, and how many times they've been back in the last year. And we use that for targeting. The biggest way to fail in all these business models is to spend a lot of money on the wrong people. And it's really, really easy to do. All of the return on investment is really about focusing on the right patients. And without hard data, it's really easy to fail in that. We've got research, data, and evaluation, finance, admin, and legal. That's the simple stuff. Those are, in the business literature terms, that would be the functional silos. That part of the org chart makes sense to me. The part of the org chart that we've really noodled about and we keep moving around and struggling with is the clinical programming side. So I've divided this into 3 segments really built around the data. The first segment is focused on complex patients who are going to the hospital and the emergency room too much. So that's our care management and care coordination work. The second segment is the primary care segment. This is focusing on people that do have a relationship with a primary care provider, that belong to that primary care provider, and that primary care provider should be the accountable manager for what's going on in that office. So this is really classic work. This is clinical transformation work. This is reinventing, redesigning the primary care model. The current model we have in primary care is a passive model. It's really a failed business model. It's under-resourced, underperforming. And this is the absolute hardest thing in the world to do. We don't have a language for it. We don't really understand how to do it. We haven't divided it into normal, natural buckets of care. So this is, our longest range, most difficult strategy. And the last piece is patient engagement strategies. This is, ultimately there'll never be enough doctors and health coaches to work with every single patient in Camden that needs it. Until I get patients helping one another, I can't fix this. And my model for this is AA. So Alcoholics Anonymous has spread all over the world. It was created by alcoholics themselves. One was an alcoholic physician, and it has never had any government intervention. There's not a dime of government money, and it's probably saved more lives than anything we've ever done in healthcare. So I think it's probably one of the most powerful patient engagement models out there. I also include community organizing under this, as well as lay and professional education models. We have something going on within each of this. So I consider our organization kind of a portfolio of strategies broadly targeted to bending the cost curve and improving quality. So our current model, which keeps evolving every week, is, as I said before, we take the data every morning, and all of my teams sit at a big table, and they pull patients off of that list based on criteria, and the highest risk patients end up on what we call a high utilizer team. This is a nurse, community health worker, and social worker. These are patients who've been 4 or more times in 6 months. So these are really complex patients with a lot of complex social needs, and they're going back over and over to the hospital. These folks end up on the team for 6 to 8 months. It's a very, very intensive intervention. The intermediate risk patients get a more classic model. This is like the Geisinger, the group health, the Naylor, the Coleman model. These are patients that have been to the emergency room or to the hospital 2 to 4 times in the last 6 months, and they end up on the team for 6 to 8 weeks. This is a mixed team of a nurse, an LPN, and 2 AmeriCorps health coaches. Our sweet spot is AmeriCorps volunteers. I don't have a lot of money, and it turns out that most of the work that needs to be done can be delegated down to non-clinical staff. And that, once again, is the return on investment, is that once you figure out who you're targeting, once you figure out the nature of the work, the whole game beyond that is getting really inspired people that don't mind running around the city of Camden, and then getting them to work as a team and delegating that work down to the least costly staff member, and doing that as quickly as possible. So AmeriCorps volunteers are Dartmouth alumni. We had 1 Dartmouth alumni, and really smart kids who are in a gap year between college and med school or nursing school or public health school. It cost me $3,000 per volunteer, and they spend a year with us, and they get really good at this. They turn out to be phenomenally good navigators, patient advocates. Our model is because we have real-time data coming in from 3 unrelated hospitals, we show up at the hospital within 24 hours of the patient being admitted, enroll the patient in the intervention, follow them through the admission, participate in the discharge planning, show up at their house within 24 hours, and then go with them to their primary care appointment within 7 days. We're sitting in the waiting room. It's really expensive to send staff to go to the house within 24 hours, to go to the hospital, and then to sit in the waiting room with the patient, and then sit in the exam room when the primary care doc walks in. We didn't do that for a long time, and it's turned out to be absolutely transformative to the work. All of these docs are my board members, they're my friends, but I've never gotten so many positive emails back since when we started doing that. That the trick to this work is all warm handoffs moving through the system for these patients. And when the doc walks in and can get out of the room in 10 minutes, 15 minutes, because someone organized all the meds and all the information, I'm getting phone calls and emails back from the docs saying, "Your staff are so amazing. I can't believe this patient has been a train wreck for as long as I've known them. What have you guys done? This was the most easy, organized visit that I've ever had." It's very expensive, though, to send staff in to do that. Then the staff go with the patient to their first specialty appointment. There's usually 1 major specialist involved in every case, so we make sure that within the following week, we go with them to their specialty appointment. And once again, sit in the exam room when the doc walks in as well. And similarly, I've begun to get emails from the specialists talking about that as well. But as quickly as possible, we turf all of this work down to the health coaches. You know, the long-term fix to all this is fixing primary care, and you know, it is so hard. I mean, these are my colleagues, their offices are getting broken into, their roofs are, you know, leaking, their staff are quitting, their offices can't pay their payroll. You know, so this is really hard work doing transformative work. We're doing something in each office, so we're helping some get electronic health records, helping some build registries, we're helping some do group visits, switch to open access scheduling, do care coordination, but we picked 1 office. I had all of my board members respond to an RFP to pick a vanguard office. So one of the things that we don't do in healthcare is we have no language for the continuum from an invention or a rough idea out to full deployment and scaling. And over what we do is scale something that's not ready for prime time. So, and we don't even know how to talk about this to each other, and I need help figuring out the words, but there's something, we don't do a lot of prototyping. And then often what we do with prototyping is we don't let the people prototyping break rules. So, you know, the really organized healthcare people come in and they start to try and protocolize too quickly. So we need prototyping, we need testing, we need rule breaking, then we need slow standardization, and then we need scaling at that point. And as I'm watching around the country, people trying to struggle with population health, they don't have even a language to describe this continuation. You know, over and over, people are trying to scale all at once and they haven't prototyped, or they're trying to standardize before they've even figured out what they're doing. So, you know, the business people in the room, you know, I know there's a model for this, I know there's language for this. On the healthcare side, we really don't have the language for this. One of the things we've been playing with lately is the ER and hospital utilization literature is primitive at best. I don't think it really explains the problem. And we've been playing with kind of a typology of the data. And this has helped us a lot internally. This is 1 year of data of all the patients living in Camden from 2011 for their ER and hospital visits. Over here are segments of the ED visits. So patients who went for 1 ED visit, 2 to 3, or 10 or more. And over here are patients who are the number of inpatient visits. So let's take this cell. There were 339 patients who had 10 or more ED visits but never got admitted. That's a completely different patient than the people over here. So that means there are 339 people who went to the ED over and over and over in Camden 10 or more times in 1 year, but never scared the emergency room doctors enough to get sent upstairs. That's a very unique patient. And they require totally different interventions. They're a totally different part of the data. They have different cost structures. You would build in a completely different business model around them, organizational model. Over here, there are 62 patients in 1 year who went 10 or more times to the emergency room, but 5 or more times were admitted. So that's really interesting because that means they're really sick. If you get admitted in 1 year 5 or more times to the hospital, you're a pretty sick patient, but that means 10 or more times they didn't get admitted and they got treated and released from the emergency room. So, high utilizers get head colds too. So they come to the emergency room for their primary care and they come to the hospital for their specialty and inpatient care. And that requires a completely different intervention. We don't really have names for this different typology. We haven't, I don't think we've done enough work understanding the typology, and oftentimes we segment first by disease and diagnosis, and then we do this kind of stuff later. And what we need to do in each of these cells is describe who the people are. We need anthropologists and ethnographers to explain who these folks are. We need to segment by disease, by age, and all sorts of things within each of the segments. So, so I think that disease can be a secondary segmentation, but is a bad first segmentation. So these are inpatient high utilizers. That's where all the money is. Don't focus, every time you go to the ER, it's like rolling a dice. You have a chance of being sent upstairs, but, an inpatient visit is $10,000 a pop. An emergency room visit is $200, $300, $500, $700. ER visits are important because they're a marker of something going on. They're patients that need better primary care, but we use them interchangeably sometimes. We're not really specific in our language around these patients. So in each of these cells, in the red cell over here, there were 500 patients. It's 1% of the patients. They had 2,000 inpatient visits, 4,000 ED visits, $10 million in inpatient payments over 1 year, and $1.7 million in ED payments for the care. Whereas over here in the blue cell, there were 5,000 patients, 9% of the patients in Camden, with 28,000 ED visits, $11 million in ED payments. So the treatment over here is open access scheduling. We think that if these patients could get an appointment in real time, that not all of this would go away, but a lot of it would go away. The treatment over here is really hard stuff. It's face-to-face, warm handoffs, it's home visits, it's care in the field. This is we've been playing with visualizations of data, and this is an EKG of high utilization, of healthcare utilization for one patient. Doctors love machines that print strips out that have CPT codes attached. So, we've been sort of playing with how could you visualize a patient's utilization in a way that a doctor would understand. One of the things that we think needs to happen is that at every single visit, there needs to, along with blood pressure, height, weight, we also need to write down the patient's last year of ER utilization and hospital utilization. That healthcare utilization needs to become a vital sign because doctors won't focus on it unless it's a vital sign. And it should be shaping every visit at every time they come to the office. Blood pressure shapes the visit, height and weight shapes the visit, and their ER and hospital use should shape the visit as well. And then they should print out from the cool machine that there's a CPT code, the patient's strip. This is a little like a fetal heart monitor strip, like the doctors all stand around and look at the fetal heart monitor strip as it's printing out and arguing about what the pattern means. So we do a lot of pattern recognition of chaotic patterns in healthcare. So this is time along this axis for 2011, and this is length of stay. The blue ticks are an ER visit. This is one person. And the red lines are inpatient visits. The height of the red line and the number tells you the length of stay. So we put this in front of our teams and said, explain this to us. What does it mean? And what's going on here is that hospitals hate high utilizers, and healthcare providers call them non-compliant. They get frustrated with them, and utilization management tries to get rid of them, tries to get them out. So the patient had a 6-day stay, came back to the ER, 2 weeks later had a 5-day stay. The word on the street was utilization management has got to get this person out of the hospital. They've got a 4-day stay. They come back a few more times. They've got a 3-day stay. And finally, they come in and they get a long ICU stay, 14 days. And whatever was going wrong with them that no one was paying attention to, finally got fixed, because lo and behold, the next 6 months or 3.5 months, they're out. But they're in the ER every other day. So they're still getting their primary care, a little TLC in the ER, and then the crescendo starts again, 2 days, 4 days, 5 days, 8 days on. I don't know what any of this means. Someone's got to, do some really good work trying to piece together what these patterns mean. But we think that it's useful for providers to begin to have new kinds of visualization of all this data. The work I've enjoyed the most and has been most meaningful for me has been community organizing. We have a group in Camden called Camden Churches Organized for People. This is old school community organizing, Sololinsky community organizing. And these are local congregations that are fighting for better schools, safer streets, and we brought them all together and did a retreat in Camden where I sent them around the state. They went to see my hospital CEO, which was really nerve-wracking, and they went to see the head of a Medicaid HMO, they went to see state officials, they went all over the state to the head of the Chamber of Commerce, and we came back and we mapped the flow of money out in healthcare. So this is literally a money map of how money flows around, and we mapped out the point of view of each stakeholder. Classic community organizing, you got to know where the money and the power is, and the point of view of each stakeholder. Then in the evening we came together, and this is at a church right next to Northgate 2, the building that I showed you. And a lot of parishioners that go to this church live in Northgate 2. And this woman up here, her name is Pilar, and when I first met Pilar, she could not look me in the eye. She was overwhelmed, depressed, and angry. And she has sarcoidosis, and she got health care largely at his institution. This is my hospital CEO, the CEO of the largest academic health center, Cooper Hospital. And she got up and told her story, largely about getting health care at this institution. And she was, didn't name names, but just described how hard it is to get healthcare services. We had physicians getting up talking about how hard it is to go to work every day and not seem to make a difference for really hard patients, how frustrating that can be. We had a hospital CEO get up, standing in front of the data you just saw, and describe how hard it is to be a hospital CEO. Because if you do the right thing, you'll go out of business. That there's no, there may be a place in heaven, but there's certainly not a place in the CEO seat for doing the right thing in healthcare. The head of our Chamber of Commerce talking about how business can't afford this anymore, and a state official. And we hung a covenant on the wall. This is one of our CIOs from Virtua signing a covenant. And the covenant, literally, we all said it together. And it was a pledge that all the stakeholders have to start doing something different. That this is not about non-compliant patients, evil insurance companies, terrible hospital executives who are uncaring, or terrible Medicaid officials. That, fundamentally this is about misaligned incentives and a game in which we're all playing the game, but that no one's benefiting, and certainly the patients are being hurt the most from this. But I actually think this is doing damage to everyone within the system. So we made 2 promises that night, and these were hard promises to make. We actually wrote them on the covenant at the bottom. And our hospital CEO was worried about signing this, and we told him it's not a legal document. It's you're just making a promise, from a pulpit on a church wall. Don't worry. So 2 concrete promises. One was to try and pass legislation in New Jersey, which is a shared savings model, and the other was to work with Northgate 2 and try and innovate a solution for them and with them. And after a lot of work in Northgate of talking to residents and sort of planning and thinking, this is a ribbon cutting, and this is Pilar cutting a ribbon, and who's coming to our board meeting. She was there last week, who's smart as can be, asks phenomenal questions at our board meetings. And they're cutting a ribbon for a 2-exam room office in Northgate. So, we're bringing health services to the building rather than moving these people around. And this is Rick Gilfillan from CMMI. It's our Senator Menendez, our mayor. This is a great mayor, by the way. She's not been indicted and convicted, and she's honest as can be. And our congressman, and That office has been open for about 11 months. It was opened with no grant money. A private practice in Camden opened it, and it's because the claims data, I could make a business case that there were enough Medicare, Medicaid. In Camden, dual eligibles are what we call well-insured, you know, that there were enough well-insured patients in the building to open a practice there. So the office has about 100 patients who've switched over in the building, and I'm throwing everything in the kitchen sink at this building. For me, hotspotting is just picking something I can get my hands around and then concentrating intensely on that. So, you know, we're doing a yoga class in the building, an art therapy group, a diabetic support group, an Ask a Health provider. I'm going to just do anything I can think of in this one building. We've got a really good resident team in the building as well that meets every month. We give them data so they know how the building's doing. Our other concentrations are on the most expensive patients in this building, in the city, so the high utilizers in the city. And the third hotspot is focusing in on one practice. And in that practice, we are spending about $150,000 a year for 5 years. And we've hired an RN, an LPN, 2 health coaches, a program assistant, and a program manager. The most difficult challenge in all this work, part of the challenge are going to be the clinicians and the health coaches, the clinical side of this. There simply aren't enough people who want to run around in the community and can do this kind of work. So we've got a huge workforce problem on that side. The other side of the workforce problem is we're going to need lots and lots and lots of talented project managers. And the project managers are going to be very energetic young people who know how to do change management. And the way we nurture them is they start out as AmeriCorps volunteers and have a really hard, frustrating year of seeing how broken healthcare is from the front lines. And they do a lot of good stuff, and then we take the most talented AmeriCorps and we hire them as program assistants. And they get nurtured as a full-time staff member under a project manager. So the most important staff line I have now are my project managers. And I deploy them out to, you know, I've got a couple of them working in a Medicaid OB office, helping to set up group prenatal and well child visits. I've got another team embedded in this office that's our prototype office. So we use them as really the crux of our interventions. So that's a lot of money to spend in one primary care office. That's a lot of staff to put into one primary care office. But we think taking one place to the penultimate extreme, building out an extreme prototype for what the best office is going to look like, is going to teach us a lot so that over time I can whittle that back down and make it more efficient. So, you know, I overdo stuff, overspend, and then I whittle it back down once I figured out what the prototype is. This is data from Camden, Trenton, and Newark from 2007, and this is the top 1% of emergency room high utilizers. In Camden, it's 386 patients. They went for 5,000 visits. They had 13 visits per patient, and 80% visit more than one hospital. They go ER to ER, hospital to hospital. In Trenton, it's 500 patients, 7,000 visits, 15 visits per patient, 78% visit more than one hospital, and similarly in Newark. I think that this is very similar to the very famous article that you all published that is the basis for ACOs. And my layperson's interpretation of that article said that the average patient is loyal to the average doctor, is loyal to the average hospital, and that if you draw a line around the greater medical staff, you can make that a unit of accountability. And I think that that will work in the suburbs, probably. It won't work in Camden, and it won't work in urban communities, I don't think, because the most costly complex patients aren't sticky. They're not loyal. And that model depends on stickiness and loyalty. And if patients are moving around, it's very hard to make that work. We embodied that basic idea into a piece of legislation, and the New Jersey Chamber of Commerce hired the head of the Republican Party of New Jersey to run around the state with me working on this legislation. We had 5 very talented attorneys volunteer to help write the legislation, and we tracked the federal bill and used some ideas and language out of that. And this is for a Medicaid Accountable Care Organization demonstration project, a Medicaid ACO. Now, an ACO for, I don't know how you could be at Dartmouth and not know what an ACO is, but if you don't know what an ACO is, it's essentially taking what goes on at Geisinger, Group Health, and Kaiser, these highly integrated systems where the docs are all working under one roof in collaboration with the hospital, in all likelihood employed by the hospital, And the observation has been that those doctors deliver better care at lower cost. The problem we have in places like New Jersey is that it's an unbelievably fragmented marketplace. It's literally, you could go 10 blocks and hit a new hospital. And there's like a small practice on every corner. So we have an unbelievably fragmented marketplace. So the idea of an ACO is to lift some of the federal rules that prevent doctors and hospitals from colluding or collaborating. Depends on which side of the ledger you're on. And allow them to work together with the presumption that they're going to do the right thing, that they're not going to restrict access to care, and that they're going to reduce cost and improve quality. And if they do, that they'll be allowed to collaborate together. So in Camden, that would mean I'd have a Cooper ACO and a Lourdes ACO and a Virtue ACO fighting over poor people or running away from poor people. I don't know which. And they would be doing vertical alignment with the homeless shelter. So it's really hard to figure out how the ACO model works in this framework in a place like Camden. And I think it's going to work out in the suburbs, but my fear is that ACOs are all about the denominator. It's all about the population, and it's all about getting the healthiest people in your denominator. Or it's about getting the sickest people in the denominator and doing a really good job with them. And my fear is that if Camden's in your denominator, you're going to hate Camden residents. And you're going to get really frustrated by them because there's not a vendor you can hire to come in and fix the Camden problem. It's a mess. It's really complex and very disorganized. So I fear deeply that if they're largely suburban-facing organizations, that if their denominator, their population stretches way out into the suburbs, but the back end of that are Camden patients, that they're just going to get frustrated with it. So what I've asked them to do is carve out Camden into a different model. And the model would be a nonprofit organization, the Camden Coalition, working together with all 3 hospitals as board members, with the churches, with the federally qualified health centers, and the small practices, together to improve quality, share data, and bend the cost curve. And that if we do that, the savings would come back to the coalition, and then we distribute them out based on quality metrics to the players in the city. Now the problem with that is that sent the Federal Trade Commission into a tizzy. Because the way the legislation works is it says you would declare a geography. So it's a geographic denominator instead of a primary care-centric denominator. And you have to have 5,000 Medicaid beneficiaries living in that geography. And you have to have 100% of the hospitals, 75% of the primary care providers, and 2 behavioral health providers and community residents on the board and playing nice in order to even get started and be certified in this model. So the Federal Trade Commission says that if you're more than 30% of market share, that it sends you into a special set of review. And certainly they have no intention of letting people get to 100% of market share, I don't think. So we put in a lot of safety provisions in this. So everyone negotiates their fee schedules the way they normally negotiate them. This is just like the federal bill, which is you do a trend line, and if you bend off the trend line, then the delta, the gap between expected cost and actual cost, if you manage to bend the cost curve, becomes the money that comes back to the organization. So we've helped the state write the regulations. It's moving through the adoption process. Chris Christie signed the bill. It had broad bipartisan support. And if you want to know what Republicans will support, they'll support better cost for patients with no upfront funding. So there's no upfront funding. I have to capitalize this. And the way we're capitalizing it is with foundation money. And the promise to the foundations is, if you want to test an idea in Camden, the sustainability model is that we can bring some of these shared savings back to support the intervention long term. Our intervention is very concrete, so putting nurse practitioners in high-cost buildings, more high-utilizer outreach teams out in the field, embedding nurses in primary care offices with the AmeriCorps volunteers, and more same-day appointments. So none of this stuff's rocket science. The hard part of all of this, everyone I meet around the country, I've met Partners, I've met Fairview, I've met Southeast Alaska, I've met Advocate, you guys, what everyone's struggling with is less the it. We kind of generally know the sort of things we probably need to be doing, but what in the world does the org chart look like? What do the job titles look like? Who do they report to? As Chris's book taught me, institutions do a really good job of maintaining a status quo. They get really good at something. And for 50 years, we've really gotten good at developing a product line that has a really high price attached to it and a CPT code, marketing the hell out of it, and doing lots and lots and lots of it. And all of the power structures inside of institutions have been built around that. And that is the status quo. And we're really, really good at the command and control structure of a hospital and maintaining that status quo. This whole model threatens to disrupt that entire status quo. And that institution, the lawyers, the finance people, the specialists, the chiefs, the very federated crazy model of all the departments will do everything they can to stop that. And that's just the nature of organizational change. And the way I've been working with Cooper to advise them is, healthcare doesn't have a research and development budget line. It's the only industry that has so much money but literally doesn't have an R&D line. They spend no money on research and development. And that R&D is the money that you're spending so that when the business model changes, you don't go out of business. And so Cooper Hospital now has a business unit reporting directly to the CEO that has a research and development budget line item, and they're told they can break all the rules, that the rules don't apply to them. And whenever anyone tries to cut their legs out from under them, they go to the CEO and he sort of pushes everyone apart and gets it done. So, we're going to have such a hard time with doing population health strategies because the people who know how to do this are at the bottom. They're paid less, they're at the front line, they don't have status and power in most of these institutions. And the people who are your cost centers, the specialists and the chiefs and all the power centers at the institution, are now going to flip from being your rainmakers and your revenue to being your cost centers. And that's just going to flip the whole place on its head. You won't need nearly as many of them. Even within individual divisions, the specialists who had bad RVUs and bad productivity, and everyone complained about them, are going to turn out to be, your brilliant providers in the population health model, because they love to talk to people, they love to bond with patients, they build relationships really well. They're going to know how to do this work. They collaborate with their colleagues. The folks that love to cut, scan, zap, and hospitalize patients that are your stars right now that make lots of money are going to suddenly fall to the bottom and may have to move around the country, or maybe they're going to have a hard time finding a place for themselves. So, so we have incredible challenges moving forward, and it's a very exciting time, I think. So some of my lessons from Camden is that it has taken me as a provider, the mentality of being a provider running from room to room to room is completely different than running a 34-person organization. Totally different. I have had to unlearn everything. It really requires a very different strategic ability to filter, focus, and segment. I have to have a lot of comfort with ambiguity and willingness to tinker, and then slowly begin to systematize and standardize. And there's a famous Heifetz article that has just been wonderful for me that talks about adaptive change and that fixing healthcare in Camden, and for many of us, will be an adaptive challenge, not a technical challenge. And we retreat all the time in meetings to making it a technical challenge. And it's really about having hard discussions and saying things to people that they don't want to hear. And having people begin to reconceptualize their mental model for who they are, who their patients are, how they interact with their patients, and what the whole organization does. Totally foundational stuff about what it means to be a hospital and a healthcare system. And that you have to have passion for moving towards standardization and efficiency, but only when the time is right, not too quickly. My best example of failure in that is I was so nervous. Anxiety pushes people in all different directions. Some people, it pushes them to, become super type A and super organized. Some people, it pushes them up on the balcony and they just sort of become dreamers. And when I was getting our high utilizer project off the ground, I was getting so nervous about the project that I made a 15-page intake form. I spent like days and days and days on Word just making this perfect form that I didn't want to miss any data element. And I gave it to my staff and they went out and met the first patient, and my social worker just came back and said, no way. This is about relationship building and this form is getting in the way. So I think that's a small example of we build protocols and standardization, and I love standardization in healthcare. It's so important, but we got to time it right and do it right. And we got to standardize the right things as well. And meaningful solutions are very local, gradual, and required chunking. Everything I've said works, I think, in Camden. We're beginning to figure this out. It's going to look similar but different for you all. That the basic elements of needing to tinker, of standardizing, of creating feedback loops, of data, of inventing. There aren't even job descriptions for all of the people you need. Like, no one knows how to do this stuff. You're going to need an army of talented 20-year-olds running around, sitting in practices, helping to transform them, because you'll go broke if you spend lots and lots of money. And if you embed nurses as your change agents, you're going to waste the talent of all those nurses. You're not going to have enough nurses. Rather than doing change management in a primary care office, they need to be out in the field seeing your high-cost complex patients. So, so what works in Camden won't necessarily work here in other places, but the elements of the business challenge and of the operational challenge of the systems engineering will be very similar from place to place to place. So thank you so much for the chance to come up here, and why don't we do questions?
My name is Kate Clay. I'm a nurse, and my work has been in shared decision-making here at Dartmouth. Talking about training your health coaches, I'm curious as to how you train them. What is the protocol you use to train them, and how do you know they're good at what they do? So where did you come up with that curriculum?
We don't have enough of them, and we haven't been doing it long enough. So we're making it up as we go at this point. We do have a curriculum, and I had my health coach from last year, who's an extraordinarily talented Penn student that took a year off. She's a med student, who was a AmeriCorps health coach. And she worked really closely with talented nurses, and they all learned this together. And then she wrote a manual on what she's learned, and she trained the next set of health coaches. So I have not standardized this, and I've looked at different curriculums, and originally we used a community health worker who was trained in a community health worker institute with a fairly standard curriculum, and that was an abject failure. And what we have found is that there are two varieties of community health workers that we're going to use. There are these college-educated kids that make great navigators, and then and they also bond really well with the patients, but they need a Camden resident working with them to give them legitimacy. And then for the Camden resident side, I've had much better luck with medical assistants as health coaches. Because when I took someone who'd never worked in a medical office, put them out in the field, they were talking to their boyfriend on a cell phone, and they were running amok and disappearing for hours at a time. And so it turned out that hiring someone who'd worked in a medical office for years, had a lot of training and mentoring, knew the language of how to get people into offices and how to move around in the healthcare system, they made a much better health coach and a community health worker, if you will. So it feels to me like this whole area is kind of disorganized and it's a mess. And the nomenclature for this category of people is all over the place, and it's not clear what the buckets of work are yet for them. So talk to me in a couple of years once we've standardized it, and that we're still figuring this out. And the key, I think, though, right now is for me to have a good enough ratio of super smart, talented nurses and social workers to AmeriCorps volunteers so that they're really mentoring and shadowing. And there's a lot of, a lot of work with them before we figure out how to standardize it as time goes along.
Jack Wender. Jeff, it was a wonderful presentation, and I haven't seen small area analysis used with such skill and efficiency for a long time. Tell me something about how the next phase comes out when we agree that, particularly in New Jersey, that you've overcapitalized hospitals. You've taken an awful lot of money out of them. What strategies do you see for actually accomplishing that? The shared savings concept presumably would allow you to make massive downsizing, but could the institutions really trust the idea that this is going to go on long enough so they can pay off their bonds and otherwise take their surgeons and send them someplace where they'd like to go?
We passed the legislation in New Jersey. The fact that New Jersey is #1 in the Dartmouth Atlas, and I printed out all my maps, and number 50 in the FTEs of primary care and specialty care, I rode that and rode that and rode that fact. That part of the reason the Chamber of Commerce was so excited about this work was my presenting the Dartmouth Atlas data to them and saying, look, we're such an extreme outlier in New Jersey, we got to do something, but that I don't think I can start with the suburbs. That if I do that, I'll get my legs chopped out from under me. That why don't I figure this out in Camden, and then once we politically, if the poorest city in the country bends the cost curve, it proves fundamentally that it's a moral challenge, but it's not a technical problem. So I don't know what in the world to do with New Jersey. It is such a mess. And in some ways we've made the largest economic bubble in the world. It's 18% of our economy. It's growing to 25% of the economy. Housing is 11% and finance is 7%. So I think it's going to be stunning and staggering because, as most of you may know, hospitals and doctors are the bulk of the spending. So the only way to balance the long-term federal debt is going to be to take money away from doctors and hospitals. And they can't afford to do it. Their fixed costs are so inflated and they're so overbonded and overleveraged that they will crumble like a house of cards. The next great American bailout are going to be academic health centers. So I don't know what to do in New Jersey. And I think fundamentally the trick is to plant enough seeds of good ideas that when the whole thing collapses, when the complex adaptive system goes through a state change, political leaders are going to be casting about for ideas to grab to rebuild the thing. And I hope we don't just leverage the thing like we did in banking, and housing, but that we have a chance to actually fix it. So I'm kind of putting blinders on to New Jersey and just hiding in Camden still, figuring that if I can do it in Camden, and gather enough attention and clout in New Jersey, that when the time comes and the thing's falling apart, that I can leverage up good ideas. There have been a lot of hospital failures in New Jersey, and I think there are two ways to do this in New Jersey. They have a rescue fund for hospitals, because when they fail, there's a lot of people hurt in the process. So what I think they should do is take that bucket of money and put it out and say, any hospitals that merge and consolidate can grab this bucket. But if you don't do it in the next 6 months and announce it, we're going to take the bucket away. And we're going to give you so many carrots if you merge and consolidate. But if you grab the bucket, you have to go back to rate setting. And that, New Jersey was a place, that I think was where rate setting came from, certainly DRGs, but, that if you're going to grab that bucket, that you have to go back to rate setting. So this is back to the price utilization thing. The problem is that a system that only owns one hospital is not very good at managing that hospital, whereas systems that own multiple hospitals end up with a much more talented board and management layer that is much better at doing Lean, Six Sigma operations and can actually do population health. They'll have the talent level to be able to do that. So I think we need to get all these little onesies and twosies hospitals to aggregate up. But if you do that, you'll go off the chart because they'll now have market share and can negotiate higher prices. So the only way to fix that would be rate setting. Or maybe they all congregate into ACOs. I just don't know. I don't know that they could pull it off. As little onesies and twosies, I got a chance to look at some of one hospital's data, and it turned out that half of their patients aren't loyal to their hospital. So the primary care patients for one health institution across the whole region, half of their patients were going to all the other hospitals. So, that's a stickiness problem, and I don't know how you do integrated care when you can't compel the patient into a narrow network when no one is sticky. So I don't know what to do in New Jersey other than hide.
Hi, Greg Meyer. I'm new to Dartmouth Hitchcock, but I was at Mass General prior to this, and there's one fact that you found that actually didn't comport with our experience with high-cost beneficiaries, and that was we found that the patients who were really complex and who were really, really sick, the tip of the iceberg, were incredibly loyal, in that they went to the same place over and over again. And that was the way that we got around that issue that you showed there with the three competing ACOs, and it doesn't work. Shared savings did work there because people did come to a single loyal provider when they were super, super sick.
When it's brand name Mass General.
So that's a really important fact, and I think we need more and more cross-market comparisons to figure out how true that is, and I think it's going to be completely different in different marketplaces. What we see happen in Camden is that these folks get their feelings hurt, someone yells at them, and your folks going to Mass General are probably, their Medicare patients probably of higher station in life than the people I'm seeing in Camden, and they get looked at the wrong way by one of the hospitals, and then they literally go to the next. And literally there's an event. Some nurse looks them the wrong way, some doc kind of is mean to them, and they literally go to the next place. It's literally that, is what we see. So I think if the marketplaces that see more fragmentation are going to really have a hard time. The marketplaces that have more loyalty and already have more consolidation will move into the ACO model very quickly and probably succeed at it. So.
I wonder where you think you're going to get your primary care doctors? I mean, it seems like that's the deficit, but the sort of the most obvious deficit in this plan going forward is that you have these boarded up practices.
I think it's a huge issue, and that's not just true for Camden, that's everywhere. I mean, it's going to be a little bit like at the height of law firms at their growth, they were locking these kids down in the first year or second year by dangling lots of money. I think that's going to happen to family medicine and primary care residents, just because there's not going to be enough of them. People are going to try and sign them into contracts. The other strategy besides making more primary care providers, which isn't going to happen, is going to be figuring out how to leverage and delegate as much work as possible. So if we re-engineered and reconfigured offices, so a small example was, does any primary care doc ever need to touch a normal lab result? We spend probably an hour a day looking at normal lab results. It's a total waste of time. All of that work could be delegated. The number of times that you order screening tests for patients probably takes up an hour a day. A primary care provider should never order a screening test. It should be delegated down to a 22-year-old Dartmouth graduate who's running their registry and pulling all that stuff out. Even abnormal tests, if the mammogram says, please order repeat views, all of that should be delegated to someone doing that, and it should never even get to the doc. The problem is that we don't know how to play nice in healthcare. We don't know how to trust. We don't know how to train. We don't know how to work in teams. So you have to have confidence in your team because there's all this medical, legal kind of stuff overhanging you as a provider. So I think that's part of it, is magnifying our efforts through delegation. It's not going to be automation. It's going to be re-engineering and reconfiguring and delegating. We think it's going to be automation. It's just not.
Any other questions?
Randy Lee, I'm an orthopedist. I had a question for you about how you plan or what's your model right now for getting specialty care for these individuals and how that's working out and what kind of pushback you're getting or cooperation or whatever.
So we have an interesting dilemma in Camden, which is, much like the hospitals, none of the specialists are fighting over our patients. So, these two buckets of costs that I started out with, one being unnecessary specialty care, and the other being fragmented, uncoordinated care. I have less of the unnecessary specialty care than exists out in the suburbs because no one's fighting over doing more stuff to Camden residents. So my strategy has been to hire the specialists, like point 1, point 2, send them out to meet with the primary care providers, and to train the primary care providers. So we hired an endocrinologist, and his goal was to work himself out of a job. And he had a 9-month wait for the specialty office in Camden. And what would happen is the primary care providers wouldn't start insulin, a couple of them, because it was too much work. The patient would get DKA. They would go into the hospital. He would start insulin on him as the inpatient endocrinologist. And then they'd be referred back out, and the docs didn't want to manage it. And then they'd refer to him, but it was a 9-month wait, and they just kept cycling through. I mean, it's such a bizarre small city that you can see all these weird feedback loops going. So we hired him, and he went out and trained that staff at that office on how to do insulin starts, how to manage insulin. He's been all over the city working with the primary care providers. They email him, they call him. They've worked really closely with him. So we're going to try and do that specialty by specialty by specialty. We've been working with a pulmonology group to do group pulmonology visits. So it's like an assembly line. The patient walks in and they get registered, then they go to the next desk and have an intake. They go to the next desk and they have pulmonary function testing. They go to the next desk and they get fitted for a spacer and taught how to use it. And then at the end, they end up in a room for an hour and a half with the pulmonologist. And the pulmonologist loves it. I mean, we have to practically pull them off the stage at the end of it. And the patients love it because they feel like they had an hour and a half with this great pulmonologist who's hanging out telling them stuff. And they walked out the door with their meds and all this education. So, and that's fundamentally a more efficient model and more cost effective than the current model. So, we're trying to sort of rethink how specialists deliver care. For our OB clinic, our prenatal care for poor women in Camden is just totally broken. And we're working with a group to do group prenatal and well-child visits. So you take 15 moms, cohort them, and they walk through the pregnancy together. So there's a model like this called Centering Pregnancy and Midwifery as well, but then it turns into a well-child group afterwards. So I want to go through neurology and orthopedics and all the different specialties and think about how can we redesign, reconfigure, and reconceptualize what their care model is. And I think it's easier to do in Camden because no one wants to do more things to our folks. So.
Well, thank you very much.
Thank you.